So welcome everyone, first of all, and this is a kind of end of the year LTC COVID webinar. I'm really happy to let you know that we've had some good news in relation to funding, and we'll be able to start a more sustained webinar series next year. We'll probably go back to doing every 2 weeks, although at the beginning of the year, I think there's a bit of a backlog of people who'd like to speak and lots of topics that people have suggested. So we'll probably start on a monthly basis and then by about February, go back to every 2 months. So today's webinar is recorded. Please be aware it's going to be made available as well, and we'll share the slides. This webinar is a bit of a conversation, and we're going to go on a bit of a tour around the world. First of all, we're going to talk about where things are at in terms of long-term care and COVID in quite a big number of countries. We'll have 1 or 2 slides per country. We're going to have sometimes more than 1 speaker, so please, everybody, try to stick to the time, so no more than 3 minutes. And then we'll have a broader discussion. The topic that we're discussing is what have been the experiences of the 2nd and 3rd waves, and also what are the perspectives in terms of vaccines and beyond, as in policy developments you might expect in the long-term care sector. So without holding you up anymore, I'm very delighted to introduce the first speaker. That's going to be Leichsenring, who's going to be presenting on Austria. And I'm going to fully share my slides. And right to the top, that is shared. Yes, excellent. So here we are with Austria. Kai, the floor is yours. You've got about 3 minutes. Thank you.
Yeah, thank you. I owe my wisdom also to Andrea Schmidt and Heidemarie Stafflinger, who are supporting me in keeping Austria up to date. But as I see, there's also Stefan Leibelfinger from Austria online, so perhaps he can add some words at the end. I just wanted to show the very interesting development, or interesting but at the same time sad development, because we came over the first wave relatively well. Hang on, now the but now in the 2nd wave we are facing real problems, as we are now, in terms of total cases per population, quite on the top across Europe and across the world, I think even. And this then has also an impact on care homes, as we have seen from this study of ECDC, that there is a correlation, of course, between total cases per population and then total cases in care homes. Unfortunately, there seems to have been over the summer some relaxed approach, also within care homes, so masks not everywhere, not a lot of testing, or not sufficient testing, and of course visits. So this is the result as of today, that we have, or as of actually last week, that we are now at the number of 1,550 deaths in care homes, and Austria has only 8.9 million inhabitants. So there we now hope, although also the lockdown has been cancelled again. We'll see what happens over Christmas. It was also interesting to see in the media that while in the first wave, the key problem was this specific Austrian characteristic of the 24-hour care. Now it was mainly on the care homes. Perhaps Stefan Leibelfinger, perhaps you would like to add something on this?
I don't want to, and it's Michael.
Michael, yes.
Yeah, no problem. I don't want to add anything because I think the 3 minutes for Austria are over anyways.
That's okay, and we'll have a time for a discussion afterwards, so you can add to that as well. So we're going to then move to Brazil. Thank you very much, Kai. And from Brazil, we've got Patrick Alexander Wachholz. I don't know if I pronounced it well. The floor is yours, Patrick, for 3 minutes.
Thank you. I can use, thank you. Well, my name is Patrick, I'm from Brazil. The next slide, please. We are showing a little bit about what is happening in Brazil on July, oh, sorry, the last.
Sorry.
On July 29, Brazil hit a peak daily caseload of over 69,000 cases with around 1,006 deaths. We are not now in what we think is a second wave. Brazil is probably starting a high number of cases without even leaving the first wave. Escalation in the infection and death rate has taken place against a background of a major political crisis. Our president has permanently opposed to lockdowns and frequently encouraged Brazilians to get back to their normal lives because the economy is something important. And the next slide, please. What we are now seeing related to long-term care is that we have more than 5,000 long-term care facilities in Brazil. This is only an estimate because we really don't have national data on care homes. We have some information related to the Brazilian Unified Social Assistance System, but they only get in touch with less than 1,050 facilities. We estimate that there are over 300 older residents living in more than 5,000 facilities in Brazil. We tried to get estimates of infection and deaths in Brazil, but we only get secondary data from the public prosecutor's office. Here in this table, we have data from May to June, from June to August, and from September to October. The next slide, please. The occurrence and the number of deaths in care homes in Brazil are a little bit lower than in other countries. We are not really sure if this have relation to early banning of external visitors to long-term care facilities. One early estimation using the a weighted percentage of 44% of deaths was thought that we could have more than 100,000 deaths just in care homes, but we really didn't see this kind of number. Despite the window of opportunity for creating public policies informed by evidence, virtually no progress or improvement has been seen in long-term care sector. And what can we expect from vaccinations in Brazil? These are just some of the last informations published in our news. There is a growing parcel of population that does not want to be vaccinated. Researchers cited in the Brazilian government COVID-19 vaccination plan say that they did not endorse the document. In the middle of the pandemic, the government made a change in the COVID-19 reporting system in Brazil. So we have the official data from the government and at least 3 or 4 different estimations from another sources. Next, please. I think is the last one. This is just a survey we conducted in 368 care homes to understand how managers of these care homes were preparing their homes for the pandemic. Most of them answered that the facilities had the necessary infrastructure to accommodate COVID-19 suspected cases, but most of them did not have personal protective equipment, and they had a lot of difficulties to receive subsidies or external financing for preparation and facing the pandemic. I think we can come here and discuss more information later. Thank you.
Thank you very much, Patrick. And next we're going to India, and we've got Suvarna Alladi. Suvarna, you're there? Can you unmute?
Yes. Hi.
Hi, Suvarna. You've got 3 minutes.
Yes. So I think as I think most of us here know, India has the second largest number of COVID cases in the world. And but then that's given the large population of people itself. And the government announced a complete lockdown in March because in a way, news from other countries and learning from other countries has helped India cope with the COVID-19 pandemic. We've been a couple of months behind in the way the disease has spread in our country. So in March, there was a complete lockdown, and that was fairly well followed, which was excellent for containing the spread of the virus. And then in a phased manner, the lockdown was called off, and then it was opened up. While it caused a lot of economic problems with migrant labor, there was some kind of infection prevention, and the numbers went up. We are actually right now, the case load is decreasing. The per day number of cases, about 30,000, is kind of less than before. But our monitoring agencies, at the center, the Ministry of Health, the Niti Aayog, the Indian Council of Medical Research, have warned that there might be an increase. They have been talking about the second wave that other countries are facing. So they warn us that especially in the upcoming winter here, there might be an increase, but we are as of now not seeing it. Regarding long-term care, again, like in most low middle income countries, we do not have institutions that take care of people with chronic health conditions. Majority live at homes and the families. So there are a few long-term care institutions, but they're literally very, very few of them, nursing homes or residential care. Now I'll directly go to dementia because this is what, thanks to Adelina and Peter, I think we attended, they organized, the LTC organized the first long-term care webinar like this, very early stages. And what we found was in the phased lockdown period, the problems, as you can see in the slide, was of accessing services, but people with dementia and their caregivers, for them, what was highlighted was the unchanging reality of caregiving. It was difficult before, it continues to be difficult now. Now, we repeated this survey in persons with dementia in 2 cities, in Hyderabad and Bangalore. And what we interestingly found, this was done in October, November, that the proportion of persons with severe dementia actually seemed to increase. So people for some reason progressed. This we believe, this correlated with the fact that they had were not able to go out. Their functional rehabilitation activities were all interrupted. There was social isolation, which is not good for the brain. And there were a larger number of people who developed neuropsychiatric symptoms, anxiety and eating disturbances when they did not have them at baseline during the lockdown period, beginning of the pandemic. And the number of carers who experienced distress was also nearly doubled in correspondence with the increase in the severity of dementia. Regarding vaccination, the government has a nice, has put out a draft SOP, and elderly people above the age of 50, frontline workers, healthcare workers, and those below the age of 50 with comorbidities are going to be in the priority, because we have a universal immunization cold chain in place. We do vaccinate it's a universal free immunization for other infectious diseases. They will use this as a chain to roll out the vaccine when and if it actually comes through. So that's all I have to say. Thank you.
Thank you very much, Suvarna. Thank you. And hold any questions for the Q&A session afterwards, please. And we're going to move to Ireland, and Maria Pierce is going to talk to us. You've got 3 minutes, Maria.
Thank you. Okay, you can move to the next slide, Adelina. Okay, so Ireland, we have, I suppose, at the moment, a 5-level plan for restrictions, so it's 1 to 5, 5 being the highest level of restrictions, and we've just come out of that about 2 weeks ago, so we're back down to level 3. We have currently the lowest incidence of COVID-19 in Europe, and to date there's been approximately 1,861 COVID-related deaths, and older people continue to be the most susceptible to COVID. And what has changed since the first wave is that the proportion of those deaths, can you hear me? The proportion
yes, we can hear you, Maria.
Okay, the proportion of those deaths that are linked to nursing homes has reduced. So it's at 35% now, whereas in the first wave, that was around 55 or above. So that seems to be due to the measures that have been introduced around April and May in Ireland. What continues to be a major concern is the restrictions on visiting to nursing home. Now, the HSE has just released some new guidelines on visiting restrictions. So it allows one person, 1 visit per week to nursing homes. And if we go back up to 5 weeks, level 5, that will be 1 visit every 2 weeks. And there's a major concern that this really isn't enough engagement, you know, for either the person, and most people in nursing homes are people with dementia, and also their family members. The other thing that hasn't changed really since the first wave is that most of the group-based supports, particularly for older people and people with dementia, remain closed. So things like daycare centres, community-based cognitive stimulation therapy groups, all of those kind of things, all remain closed. Some of them have moved online, and there are some day care that's being provided in people's homes, but the group social interaction and the peer support is gone from those kind of interactions. Residential respite hasn't been available since March. So there's been a huge impact on both the person with dementia, older people, and family carers who are providing care to these people. And in addition to that, the voice of older people, the voice of people with dementia and the family carers doesn't tend to be very strong in the development of policies or responses to COVID-19. And there seems to be a consensus that the issues in Ireland's long-term care system that we've long recognised have merely been amplified by COVID-19. So the bias that there is towards nursing home care in terms of funding and the governance that's arm's length, particularly in relation to private nursing home care and private home care is an issue. And also the low base from which community-based supports are provided to older people and people with dementia. There's also a concern that because of all the budget implications of COVID-19, that the funding may not be available to actually provide the services that we really need for older people and people with dementia once we get through COVID-19. So there's concerns about that. In terms of vaccine allocation, the government have just recently produced a provisional vaccine allocation list of groups, really, and people over 65 in residential care facilities are the highest priority. After that then comes healthcare workers, and then people over 70. So there's a whole list of 15 groups and how it's going to be rolled out to those 15 groups. I suppose one of the issues is that there needs to be clarification on family members who are visiting nursing homes and also family members who are caring for people with dementia and where they fit on that, that list of groups. And I suppose the other issue will be the same for many other countries, is really rolling out a program of vaccination. So they're the main issues at the moment, I suppose.
Thank you very much, Maria. And that's a very good question about the visitors to people in care homes and vaccinations. Thank you. We can pick on that later. It'll be very interesting to hear what other countries are doing too.
Okay,
so
thank you.
I'm going to move to Israel. And is it, so I think it's Sharona and Shuli, but I don't know if your colleague is joining as well. Very welcome. And I'm going to move to the next slide. Thank you.
Okay, so thank you very much. I'd like to first of all introduce the members of the team. We've been working on researching what's happening with the COVID-19 and long-term care facilities in Israel from the beginning of the pandemic. It's Boaz Hovav from the Max Stern Israel Valley College, and Gal Horowitz from the Ministry of Health, and Shuli Brammli Greenberg from Brown School of Public Health in the Faculty of Medicine, Hebrew University in Jerusalem. So first of all, if we can show the next slide. Thanks. Okay. Israel was one of the first countries to introduce a general lockdown as a mean to try and flatten the curve. Nevertheless, the proportion of COVID-19 deceased within the long-term care facilities and sheltered homes residents in some weeks have reached over 65% per week. So it's worthwhile to note that the percentage of inpatient long-term care elderlies in Israel is relatively low. We are under 2% of the population. So when we talk about reaching up to 44% cumulative deaths of COVID-19 within the facilities, that's a relatively high number compared to other countries. Next slide, please. So after a cry for help by the long-term care facility managements and the family members of the elderlies within institutions and sheltered housing, the Prime Minister appointed a national level force team called Fathers and Mothers Shield. This was during mid-April, and within a week, they released directives, full directives of how things should be managed within long-term care facilities. We identified three main points that are the tripod of managing the high risk of morbidity and mortality within the long-term care facilities. The first is changing the testing policy and introducing screen testing. The second was managing the visitation policies, because what happened before was that there were different and contradicting directives coming from different ministries. And the third is setting up coronavirus wards within geriatric institutions. I will explain about these 3 points. Next, please. So screen testing started by the beginning of May and rose up to over 50,000 samples per week, which is more than 40% of the entire population of long-term care facilities, staff and residents, when we're talking about long-term care facilities, not only for the elderly and sheltered housing. So it's a lot of testing that's been done, and all the staff had been going through at least one sample per week. And you can see the figures here. They show the confirmed cases within long-term care facilities. They more or less match the curve of the general population in terms of confirmed cases, but you will see that the beginning of July, that's when the real full-scale screening had begun. The confirmed cases within the long-term care show a peak which is higher than what we saw in the general population, and that was due to the testing that was done. So they managed to identify these cases before they became an outbreak, and it was very, very clear that this may be the main point and the main mean that should be financed and managed in order to stop the outbreaks within the long-term care facilities. Next slide. So about visitation policy, this is a more complex issue in terms of alternative cost, because while when we're talking about testing, it's mainly a matter of cost. Here, the task force is trying to balance the social needs of the residents and families with the risk of introducing the pandemic into the institution. So the main change was the understanding that the policy should be different for different sections or wards within the same facilities. So if I have a facility which has wards for very highly dependent people, and on the other hand, we have sheltered housing with fully independent people who have chose to live there because of their social needs and wants, they should be managed in a different way. The risk is different and everything around it should be different. And also to take into consideration the situation of the environment that's surrounding the facility. How bad is the morbidity and the infection rates within where the facility is located and where the staff is going back and forth on a daily basis. What you can see here in this graph is the coronavirus wards, beds within geriatric institutions. And the idea was mainly to try and manage the expected overload of patients in general hospitals and to try and avoid the transferring of dependent patients as much as possible. So the plan was to have almost twice the amount of beds for the winter months. And we're during the midst of the second wave. And as per last week, although the talking about vaccination, etc., the plan is still in reach. And they're still opening right now new beds and new wards to try and cope with what's expected with the coming months till the vaccination hits in. Next slide, please. So if we're looking at these graphs which show the cumulative death overall in Israel and among the long-term care residents, I think we can ask or answer for the question of, have we learned anything from the first wave? I think we have, because considering the second wave, and I think that's very much like what was described in Austria, in the long-term care facilities, things were not as bad. On the contrary, there is still a lot to do. And the plan is, if I'll take 30 seconds to say something about the vaccination, they are working here to try, the task force is trying to make sure that the residents and the staff of long-term care facilities will be with the first wave of receiving the vaccine, together with the health employees. And they're discussing also about all the long-term care patients and staff that is treating these patients in the community, because most of the long-term care in Israel is delivered community-based. We're talking about 90%, if not more. That's it for Israel.
Thank you very much. And we're going to move to Italy. And please hold on your questions. Also, you can write them in the chat box if you want to make sure you don't forget, and we can pick them up earlier, because I'm sure there are lots of questions already. So we're going to move to Italy. Our next speakers are going to be Elisabetta and Eleonora. You can unmute now.
Thank you.
About moving the slides.
Thank you. So as Adelina said, I'm here on behalf of the Observatory on Long-Term Care, and the team is made of Elisabetta Notarnicola, Sara Berlotto, and Andrea Rotolo. The first thing I would like to say, which is really important, is that we have no figures to show you, not because we didn't look for them, but because our system, Italy, still doesn't publish and doesn't actually collect any data on deaths in long-term care facilities. So this is a major issue. It was in the first wave, and apparently we haven't learned it also for the second wave. So this is why we won't show you any figures, unfortunately. As concerns what went wrong in the first wave in Italy, we identified three major issues. besides the one on data that I just said. The first one relates to the total absence of coordination among long-term care facilities and acute care. Basically, nursing homes were required to become and behave as COVID hospitals. So they were expected to treat the elderly, positive elderly, though without any transfer of specialized staff and services. The second and related issue concerns the prioritization of resources. So the government decided to prioritize, and this was a correct choice, the supply of PPE and staff to hospitals. Still, they did not decide to do it for nursing homes. So nursing homes were not prioritized for the supply of resources they needed to tackle the pandemic. Third, there was the absence of testing and screening of COVID-19 in nursing homes. So basically, the nursing homes were trapped because they had a lot of elderly ill. They could not test them. In some regions, it was also forbidden to test for positive elderly. They did not have a priority for PPE supply. They did not have specialized staff, and still they were expected to treat the elderly. So that's part of the explanation for some of the huge numbers of deaths we had in the long-term care facilities, and that we know from a survey from the National Institute for Health and from the media. Next slide, please. We learned something from the first wave. So first of all, now we have guidelines and protocols for the integration between nursing homes and COVID care centers. So now it is a bit more fluid from one setting to the other. Secondly, now nursing homes can rely on adequate supply of PPE. Still, we have no plan to increase the workforce supply. And actually, we had some paradox because the national healthcare system attracted and contracted most of the clinicians in nursing homes that were previously working in nursing homes. So it's something like the system against the system, and still nursing homes are lacking professionals and specialized staff. Third, now in most of the regions, though not all of them, we have a structured and spread testing and screening campaigns. So now at least we know if we have some positive cases, and usually they are treated and brought to specialized COVID care centers. Last, as concerns the vaccination plan, at present, we have no specific guidelines for the promotion and the vaccination for the population. What we know from the government is that nursing homes, residents and personnel will be among the first groups to obtain the vaccine together with the healthcare staff. So at least they will have some special attention from the government after the great neglection they had in the first wave of the pandemic. So I would say this is all for Italy.
Thank you very much, Eleonora. We're going to then move to next country. Actually, we're going to move to get a bit of an overview from Latin America, from Peter Lloyd-Sherlock. Peter, you've got 3 minutes.
Hi, Adelina. Yeah, I'm a bit of a megalomaniac. I can't just do a country, I have to do a whole continent. The first slide is, the point was about waves 2 and waves 3. A lot of countries in Latin America aren't really seeing waves in the sense that we are in other parts of the world. Peru, which was one of the most badly affected countries, did. Between June and the end of August, there were large numbers of deaths. There have been hardly any deaths since the middle of September. But we can see here, for example, in Colombia and in Brazil and in Argentina and in other countries, and certainly in Mexico, that this sense of waves just doesn't really play out as far as the official data let us see. So I don't think that's necessarily a helpful framing concept for some of these countries. Next slide, please. In terms of, sorry,
you told me you'd stick to the single slide. Sorry.
Oh yeah, but it was the other one that I sent you when I said just a single slide. But don't worry, it's fine.
So sorry.
I can just say it. No, don't worry. Long-term care facilities. We've already had some interesting observations, which I agree with, from Brazil. you know, we know very little, but there are some local areas in different parts of Latin America for which it's possible to get a little bit more information. But nationally, I think Brazil has probably got more information than anywhere else, and even that's very limited. But you can see some big variations of local experience. And on the Corona Older website that I help run, we highlight two particular locales. One is a medium-sized city in Argentina called Rosario, where over half of the coronavirus deaths of all ages have occurred in care facilities, even though they only have a few care facilities. Which begs the question, you know, what were they doing badly, which maybe they weren't doing badly in Brazil? Well, apparently they also introduced an early ban on visitors. I don't know how compliant care homes were with that, but it's clearly evident that there was a very disorganized response from the local ministries of health and ministries of social welfare, and they just didn't get their acts together. And that continues to be the case because death rates are still quite high for the city as a whole, and it's still the case that about half of those deaths occur in long-term care facilities. Whereas as in Brazil, more locally, for example, in the state of Bahia, in the city of Salvador, in the northeast of Brazil, we've shown that very low rates of mortality in care homes seem to have been related to, I agree, an early visitor ban, but also a much more effective local government response, which is much more coordinated and is much more in keeping with a framework that we've developed across the group called the CIAP framework, which I have a link for in the longer version of these slides, and I really encourage you to have a look at. In terms of long-term care in the community, I had a bullet point on a slide just saying small islands of innovation in a vast ocean of disengagement. Basically, particularly when you look at primary healthcare, outreach for care-dependent older people in communities, it's been almost, you know, it's been decimated. And we don't even know how badly that's affecting people because we're not even able to find out what's going on. There are a few small, wonderful programs in different parts of Latin America where they've made tremendous efforts to work virtually to ensure that their staff do get PPE, and they have been able to do some things and make a large difference, but they are exceptions. So that's all I'd say there. And finally, with reference to vaccines, I think in terms of Latin America generally, this is a big red herring, because I think the vast majority of older people are not going to get vaccinated in the next 8 months, possibly 12 months. One key concern is that the main vaccine that's being provided to many low and middle income countries is Sinovac. Sinovac has not been trialed. Well, the evidence from trialing has not been published yet in terms of its effects and its safety for people aged 60 and above. The trials that they did, which led to its approval for use, were people in good health under the age of 60. And so, for example, the government of Indonesia just recently announced that their vaccination program using Sinovac will only include people up to the age of 59 because they say the evidence is not there. This is extremely concerning. This isn't the case with other vaccines. It varies, but clearly we really have to keep an eye on the ball in terms of whether vaccine trials are including older people and including people with pre-existing health conditions. Thank you.
Thank you very much, Peter, and thanks particularly also for this very important reflection on the perspectives for vaccination. So we're going to now move to Malta. Maria Aurora, I've got 3 minutes.
Okay, thank you.
And a lot in your slide.
Yeah, I know, because you said it's one slide only. So I tried to put in a lot of information. So basically, I'll be just reflecting on long-term care. So we've got 32 long-term care facilities in Malta. And you can see there that we're around 5,000 plus older persons within these facilities. So within the first wave, there was a complete lockdown within the facilities only. Malta was never in lockdown. It was only a very, very partial lockdown. And so basically, as you can see there on the 1st July, the public health emergency was lifted and flights resumed. Unfortunately, the public, there was some relaxation, some laissez-faire attitude, I must say, and we had some village feasts and some big pool parties. You know, Maltese summers are essentially very hot, and so those triggered the second wave. So basically from having spent almost 3 weeks with 0 cases, we gradually we ended up with 3-figure digits. Something which Malta can boast of is that our swabbing is very good to date. Since the first case was recorded, since the 7th March, we've had 467,407 swabs. So basically, we've got almost between 2,000 and 3,000 swabs every day. So we've got around 8 centers in Malta and Gozo where people can get swabbed. So then the second wave, in the first wave, we didn't have any deaths in the long-term care residences, but unfortunately, this changed during the second wave. And according to the data, which I managed to procure since the end of November, we've had 28.4% of the deaths, of 48 deaths from the 169 were within long-term care residences. What we did is that there is one particular care home which was empty during the initial days of the second wave. It had just been refurbished, and all positive cases, once they are recorded, they are immediately transferred to this care home. And basically, they're either cared for there or within the acute hospital. As you can see, we've got, now there are 41 countries which are required to present a negative PCR test prior to coming to Malta. With respect to the vaccines, Malta was very avant-garde here, and since April, May, the Maltese government had been pioneering towards securing a good deal. It had been speaking with the European Union to move together to purchase the vaccines. But unfortunately, only 4 countries, we joined forces with Germany, France, Italy, and Holland. And we've joined forces with these 4 countries, and we've secured 1.6 million doses within the first 3 companies, this Pfizer, the Moderna, and the AstraZeneca. And there are 700,000 doses from the CureVac, Johnson & Johnson, and the Sanofi GSK. The surplus, according to the Maltese government, will be distributed to other countries. We've got a population of 400,000 people. So we are currently awaiting the final EMA assessment, which is expected by the 29th December, and the first vaccines will be rolled out in the first weeks of January. So we can see the vaccination timeline there. The phase 1 will be for caring staff, residents of care homes and mental care institutions, and all older persons residing in the community 85 years and over. Phase 2, which will be approximately around about February, will be all frontliners and older persons 80 years and over. Phase 3, child carers, persons with chronic diseases, and sorry about that, and older persons 75 years and over. Then there's the phase 4, 55 years and over, and phase 5 is the rest of the population. And basically, we are anticipating that by early summer, whoever wants the vaccine, because it is not mandatory, will get the vaccine. So did we learn from the first wave? There were mixed messages, even the village feasts, even the pool parties, they were uncalled for. The burnout, the pandemic burnout, which most societies, I guess, have been living through. And we've got quite a good number of foreign carers who live in, their living arrangements there are around 10, 20 people who live together, and then they provide care the other day within the residential care settings. Lack of mandatory testing at the airport, it is still not mandatory. So even if you don't present a negative PCR test, you might not get tested. And the Social Care Standards Authority was focal towards preventing an increased number of deaths within the care homes. So how do you expect vaccinations? As the timeline, the strategy for vaccinations looks very clearly panned out. So hopefully the public will go for the vaccine, but from the gut feeling that I'm getting, that people are not so, there's a number of skeptics within the community, even within the healthcare professionals who are providing care, who are not so motivated towards getting the vaccine. So basically that's that from Malta.
Thank you very much, Maria Aurora. Thank you. So any questions for Maria Aurora, please pop them on the chat or save them for later. So now we're going to the Netherlands. Thank you very much, Florien, for updating us on the situation. You can unmute.
Yes, thank you so much, Adelina. Thank you so much also for this seminar. So yeah, I'm Florien. I have been reporting about the Dutch long-term care system since the outbreak, and recently we published a new report about the second wave in the Netherlands. So I wanted to kind of, and I did this together with colleagues of mine from Leiden, Lisa, Rotterdam, Omar, and from the Netherlands with Villa. And I want to use this graph to kind of illustrate the first bit the situation that we have at the moment. So it's very clear, the blue line is the long-term care users, the green line is the non-long-term care users, so the remaining population. The shaded area is a bit of the expected values based on previous years. And we quite see how the first wave is quite strong, that the excess mortality is quite high. In the middle, in the summer, there was a heat wave, but now you see also that the second wave has caused a higher excess mortality among the long-term care users as well as the remaining population. And it seems to be in this graph that we have been able to curb the trend, but what this graph actually doesn't show is that now we see new increase of cases, new increase of admission to hospitals. But also if you look at the graph of newly infected nursing homes, you see that there's a bit of a remaining longer duration of the pandemic. And that's actually the issue at the moment, that is, we found it very hard to control the second outbreak. So at the moment, actually, as we speak, the government is together to discuss how to control the situation. So tonight there will be a press conference, probably announcing a full lockdown of the Netherlands, which is unprecedented for the Netherlands, because in the first lockdown, we had an intelligent lockdown. You might have heard about that. And then we went for a regional approach. And then in October, we said, okay, a half lockdown, but now really start on a very difficult control situation. So it's going to be a full lockdown. So I'm quite worried about how this will affect the long-term care situation. We don't have the excess mortality figures for the last weeks. Yes, Adelina, could you click 5 times? Because I added some questions, but it's not very wise. Yes, so we were better prepared for the new outbreak, which you can see in excess mortality, but we found it very much harder to curb the trend. But the second wave still hit hard. PPE was much better accessible and arranged, testing capacity also much better. Still some issues here and there, depending a bit on regional variances, but in general, compared to the first wave, much better. What was quite different than the first wave is that there was the way we arranged a visiting policy. So in the first wave, the government said, okay, it was a centralized decision saying all the nursing homes should not have any visitors. Now, and there was a lot of dissatisfaction among the public, and then kind of government promised almost saying, okay, we'll never do this again. On the second wave, they gave the decision power to the nursing homes to decide whether they open their nursing homes, yes or no, appropriate to the situation. Staff shortages is still a big issue in the long-term care sector. We see kind of high sickness absence rate this year. And of course, there was already staff shortages in long-term care. What is different than the first wave is that there's much more political willingness to kind of introduce policies to tackle this. in how far they are actually effective, I think we have to see this. It's quite challenging, I have to say, but they're at least trying to do so with various policies. And also what's new is that in July, they introduced client councils, that actually the client councils should participate in organizational decisions, especially when it matters to the client's daily life. And you see now that they have not been consistently included in the crisis management of nursing homes, but they are doing that in some of the nursing homes, which is quite interesting, I think. Concerning to the vaccinations, I found it very hard to kind of to reflect on this for the Netherlands. What they did announce is that the long-term care personnel will be also one of the first in line. What I do think will be one of the challenges is for the big nursing homes, we know where they are located, but for the smaller nursing homes, it will be much more difficult to allocate these vaccinations. Of course, there's all the other more obvious reasons, the technical reasons of distributing this vaccine, but we also have some issues with registering the nursing homes, so where they are located, the more basic statistics. So that is it for the Dutch situation.
Thank you very much, Florien. And next we're moving to Spain. Francisco Javier, you can unmute.
Thank you, Adelina. Thank you so much for the opportunity to present very briefly. First thing I wanted to share with you is that, in fact, what I'm gonna say refers to the Spanish case within a larger project that we started as the pandemic kicked in Europe. It's a project on analyzing the impact of the pandemic on the EU15. So we basically led that research following a similar template because we were concerned about a series of questions, more or less, theoretical questions regarding the functioning of the long-term care system, and we wanted to compare what happened in Spain with other countries. So the first thing that unfortunately I have to say is that Spain has been one of the most seriously hit countries in the world. Of course, it's early to say. We will see when the pandemic is over, but for now, Spain is one of the countries that has had a higher per capita mortality, and about half, it's difficult again to say, but we will see again in some time, but probably around half of those who have died have done so living in a care home. So Spain was very particularly hit during the first wave of the pandemic. And in the second one, we have been seriously hit, but less so. And I would argue that part of the explanation for that has to do with what we could call learning processes from the first wave. So basically, the kind of the approach we had towards analyzing what has happened in long-term care in homes in Spain started with the question about to what extent these care homes were prepared for a crisis like this. And so just to tell you a little bit about the methods, we interview about 30 directors of care homes in a series of regions of Spain. And we had a very long questionnaire to ask them. And one of the first things we asked them about was to what extent they were prepared. And one thing that struck us, and we're actually waiting to receive the reports from the other countries. We have some, but some are still pending to arrive. One of the first things that struck us was the actual disbelief about the possibility that something like this could actually happen. So at the beginning, it was like, oh, well, this is something that is happening in China, very far away, has nothing to do with us. Later, it was Italy, and there's, oh, well, but the Italians, they don't get very well organized, so, but it's never gonna happen like this in Spain. As they were saying that, it was already entering into their care homes, and hundreds, thousands of people actually died. I mean, I just wanted to tell you that the excess mortality in Spain is estimated to be about 70,000 people for a country of 47 million, okay? And even if the official deaths are around 47,000, but still the excess mortality, which is what will tell us what has really happened, is giving us a much higher figure. So the first idea was this complete disbelief which is again, in a way, associated to the lack of preparedness. And lack of preparedness means that there were no protocols on how to face a pandemic, there were no materials, there were no protective equipment, and of course, there were no tests. So it was all about improvising at the beginning. And of course, when you improvise, sometimes it goes well and sometimes it's a disaster. So as a consequence, the first wave hit very strongly. In the second one, we had already learned, okay, there were protocols in place, and I will say a few more things about that later. So the second thing we wanted to look at is exactly what kind of measures were implemented once we realized how serious the threat was. And of course, what we have to say here is the fact that Spain is a very decentralized country. So very quickly, what happened was that the regions, which are in charge of regulating the long-term care sector, started to create their own protocols and their own norms, which to a large extent differ from one another. Okay, so in a way, this is like a laboratory to experiment on what works and what doesn't really work. And that's the second thing we wanted to look at, is how different regions started to look at this in different ways, and which kind of measures that they adopted ended up working. And of course, this implied locking down the residents, compartmentalizing patients within them, increasing staff, trying to increase the number of healthcare personnel within the residents, which brings me to another of the elements that we realized was a very serious problem in Spain, was the fact that the long-term care sector and the healthcare sector were very not much in contact before the pandemic. They had their own practices, their own protocols, their own ways of acting, but actually the people living in care homes didn't actually use the mainstream healthcare system. Residents had their own primary care doctors, they had their own nurses, and only were referred to the main general healthcare sector when there was an acute health problem and they had to be sent through emergency room or to be treated by a specialist doctor. So this connection between the healthcare sector and the long-term care sector proved deadly, because when the pandemic hit the long-term care sector, what happened was that hospitals were already overwhelmed with patients of less than 60 years old, or elderly people that were not living in care homes, but living on their own. So when residents tried to reach out to hospitals to provide care for their residents, they were basically turned down. In many places, obviously not in those cities where there were less cases, but in those regions where there were plenty of infected people, hospitals were simply not accepting anybody coming from a care home. And of course, they told them, as we have heard before in other countries, that they had to medicalize care homes. But that's of course something that you cannot do, really. The facilities are not accurate. You don't have enough personnel. The personnel you have is not trained for that. And that accounts to a large extent for the high mortality in these places. So in the second wave, what we have learned to actually improve very much the connection between the healthcare sector and the long-term care sector. And this has been done by appointing doctors and appointing nurses from the primary care centers into the care homes that are in their area. So by simply establishing this link, doctors and nurses could actually land in the residence, help the care providers there to organize the residents, to administer tests, and to defer patients to hospitals whenever that becomes necessary. So that has been another of the learning processes, unfortunately.
Oh, sorry, thank you. Yes. I think we need to make sure we can cover all the countries, sorry.
Yes, I'm just gonna finish by saying that some good practices that we have learned have to do with this improvement in connection between healthcare and long-term care. And finally, another thing that some regions did, which was basically extract patients that had been infected to other locations. So not keeping them in the residence, even if they had arranged for a special ward for them. It's actually much better if you can derive them into another special location, which can be a medicalized hotel or a residence that has been empty for whatever reason, and you concentrate all of the people who is sick in there so as to try to keep your residents clean as much as possible. So in the second wave, we have been much less hit, and vaccination should start hopefully in January, and people living in long-term care facilities should be first, together with their care providers and healthcare personnel. Thank you.
That's great. Thank you very much, Francisco Javier. So we're next going to the UK, and I'm going to first show you some slides from England, and then I'll pass on to some colleagues from Scotland. So I'm going to show you a slightly different picture, which is about where people died have died so far. This is data up until the last few weeks of November. And in this graph, you can see what's been the mortality in different settings compared to previous years. And what I wanted to highlight is that we have had very different patterns in places of death in hospitals. So in blue, in pale blue, you have hospital COVID deaths, but in orange, you have other deaths in hospitals. And what we can see is that fewer people than usual have been dying in hospital from other issues. But we also see the other side of the coin, a really large increase, and even a large increase in excess mortality. So much larger number of deaths than expected in private homes all the way through the pandemic, but also including during the summer when in the UK summer, when in England we had relatively few COVID deaths, we still had relatively low mortality in hospitals compared to previous years, and much higher mortality in private homes than you'd expect. And one of the reasons I'm highlighting mortality in private homes is that we know very little about what's happened in terms of mortality to people who live in the community, but we also know that overall deaths have been vastly overrepresented among the very old population, many of whom will be relying on care perhaps from their relatives in their own homes, but we really have very little information about them. And also we have very little information about how many of these deaths would actually have been COVID or not, how many of these excess deaths might have been cases of COVID that were not identified because people weren't tested. So I'm just showing you this slide to highlight the complex picture of places of death in different areas. And the other thing I wanted to show you is that in the UK, we've got hospices, which are places that provide end-of-life care. And almost consistently throughout the pandemic, we have seen that there's been a net reduction in the amount of people who've died in hospices throughout the pandemic. And I'm not entirely sure why, but I just wanted to point out that unusual things have been happening that we really need to understand if we want to get the full picture of what's happened. And now focusing on deaths in care homes. This is, again, data on excess mortality by place of death. So this is people who died compared to previous years. So the zero line would be the number of, if the line was flat against zero, this would mean no change from previous years. If it's below, it means less deaths. If it's above, it means more deaths. And in here you can see in green, this is the net excess mortality, which will involve both deaths that were linked to COVID and deaths that were linked at the time to other causes. And you can see that at the very beginning of the pandemic, there's a very big difference between the line in blue, which is the care home deaths identified as COVID, and the line in red, which are the deaths, excess deaths that were not at the time linked to COVID. And you can see that over time, things changed. And as testing became more widely available, and there was also better understanding, I think, among care home staff of the symptoms of COVID among geriatric older people, then you can see that many more deaths were identified as COVID over time. So just leaving this picture because I think it's important to see how when we look at data, we really need to be very careful about basing our estimates of the impact of COVID only on mortality that at the time was linked to the condition itself. And just to say, in terms of the second wave, we've had much less excess mortality than we saw during the first wave. So we can see at least until up to the third week of November, that excess mortality in the second wave hasn't been as high by a long way as it was in the earlier part of the pandemic. And I'm not going to go into details of why, but I'd say it's very similar to what we've seen in other countries that were hit very hard on the first wave. So, and of course, this is not over. We still have increasing numbers of cases in many parts of the country. So we'll have to see how things evolve later on. I'm not going to talk about vaccination because one of my colleagues will speak about that in the end, but now I'm going to hand over to colleagues from Scotland. So I don't know whether it's David or Elizabeth, but the floor is yours.
I'm going to start, Adelina, thank you. So yeah, my name's Elisabetta Lemmon. I am a research fellow at the University of Edinburgh, and I'll talk just very briefly on mortality in Scotland's care homes from COVID-19 with David Bell. He's going to take over the sort of second part of the presentation. So David and I have both been working on the Scotland report for long-term care COVID and the UK report as well. So we've been mostly focusing on mortality in care homes. And just quickly before I start, as somebody who's not a frontline staff member working within care homes, I think it's important to recognise that behind each of these figures that we're presenting are individual people who have lost their lives and family members who have lost people that they love. So in Scotland, between weeks 12 and 19, so from mid-March until the end of June, there were 5,868 confirmed or suspected COVID-19 deaths in total. And of those, about 2,393 occurred in care homes. That's about 41%. The chart there just shows weekly COVID deaths in the blue line and weekly other deaths, other causes of deaths in the red line, and these are both within care homes. So we can see the sort of difference in magnitudes of the pandemic between the first and the second waves. Clearly the second wave, the magnitude's much lower, but nonetheless we can visibly see an increase in deaths. Next slide, please, Adelina. And it's worth noting as well, and this has come out of a lot of the reports we've done for long-term care COVID, that it's important that we not only look at those deaths that are occurring within care homes, but also care home residents in total. So there are care home residents who have died from COVID out with the care home. And the figures in Scotland that we have show that at least 2,686 care home residents have died due to confirmed or suspected COVID. That's about 46% of all COVID-19 related deaths. And we do see that there's a difference between the first and the second wave. So in the first wave, that figure was around about 50%, and it was down to 35% in the second wave. So it seems to suggest that some of the policies and changes that we've put in place between the first and second wave are potentially helping to protect care home residents, but nonetheless, it's a significant figure. Next slide, please. And as many of you guys have mentioned, and Adelina's picked up on, that we need to sort of look at the excess deaths, because we can't always rely on the accurate recording of cause of death. So looking at excess deaths allows us to see the impact of COVID-19 on mortality, and in a way that we can compare across countries. In Scotland, in the peak of the pandemic in week 17, deaths were 178% higher in care homes compared to the previous 5-year average. And overall, throughout the pandemic, deaths in care homes were about 25% higher compared to the previous 5-year average. It's worth also highlighting that there has been research done in Scotland recently. Jenny Burton and colleagues from the University of Glasgow they looked at data across Scotland and found that in homes where there hadn't been an outbreak of COVID-19, there were no excess deaths within those homes. So it provides a sort of positive message that potentially there haven't been extra deaths occurring in care homes where there haven't been COVID-19 related outbreaks. And I'll pass on to David now for the last bit of the talk.
Thanks. On to the next slide. Hi, okay. So yes, I'm David Bell. I work with Elisabetta on long-term care and have done so for a long time. Just, I'm going to talk about the take-home messages. Clearly, in Scotland, as in many other countries that we've been discussing, COVID has had a devastating impact and exposed the vulnerability of the long-term care sector. A lot of the attention in the first part of the pandemic was given to the health sector and relatively little to social care and long-term care. And the outcomes have been really disastrous for this sector. This partly, there was a lot of discharges from hospitals into care homes that doesn't seem actually to have been instrumental in increasing mortality within care homes, but it was a reflection of fact that the health authority thought it was okay to move out relatively frail older people to care homes when there appeared to be need due to the pandemic. We have not bad data, but the pandemic has exposed the need for improving data, and there is a huge move to improve the administrative data within Scotland. But you also need to pick up on social survey type data to pick up things like the effects on unpaid carers. And as Elisabetta has said, or she's mentioned in her chat box, we have around 30,000 people in care homes, but around 50,000 who receive care at home. In Scotland, you're eligible for free personal care if you deem to be requiring that in your own home. And we know much less about what has happened in terms of care at home. However, we have got one really, really good piece of news. Next slide, Adelina. So this is today's news, and this is the first person in the Scottish care home. So care home residents have been put pretty much to the top of the list as far as the vaccination is concerned. So the Pfizer vaccine has been rolled out in the last day or two in Scotland, and this is the first care home resident to receive one, and she actually received it today. So that's our high note for our talk. Thank you.
Thank you very much, David and Elisabetta. And now we're going to move to the United States, and it's actually great to see this last photo. Thank you. So we have three people speaking from the US. We've got first Greg Arling, then David Anderson, and Mike Wasserman. Your slides will come one after the other. And floor is yours, Greg.
Okay, thank you, Adelina. Well, to quote from Dickens, these were the best of times and these were the worst of times. It was the age of wisdom and it was the age of foolishness. So I think anyone who's viewed the United States over the last few months would find that quote to be quite accurate. But let me first, before we get into this slide, talk about the best of times. So today even, the vaccines, the Pfizer-BioNTech vaccines are being rolled out in the United States. People in nursing homes are on the top of the list, along with healthcare workers. And there's about 20.7 million people in this first tier. We got almost 18 million doses that they expect to send out by the end of December to 645 facilities that will be distributing them. So help is on the way. Unfortunately, we've got probably at least a month, 2, maybe 3 months logistically where these vaccines are going to take time to administer in nursing facilities and among healthcare workers and others. And in the meantime, we've got a serious problem. And you see by this graph, these are data from the Center for Medicaid Medicare Services, and these cover nursing facilities. So it does not include all care homes. If you think of about 1/3 higher on the graph, that would be all of long-term care facilities. So, but we've got good data on nursing facilities, so we're presenting that here. I think a really important point to be made here is that, well, first of all, let me say, on May 24th, we were in the sort of the downward swing from the first wave. The first wave in the States occurred in spring, very heavy, very severe, large percentage of cases. Then we had a downward trend. During the summer, we had the Sun Belt, or the Southern United States wave, wave 1.5, we'll call it. And then we had a lull through the end of summer and into the early spring, fall. And now we're on a very serious trajectory. And if you extrapolate, this is going to be a lot of cases in long-term care facilities. And if you look at that, the figures outside of long-term care facilities, they follow exactly the same pattern as this pattern. So can we go to let me point out that how closely the resident cases and the staff cases track with each other. I had to go back and double check these figures. I thought I'd done something wrong, but look how closely they track with each other in terms of change over time, the weekly cases. So if we want to know how to address this problem, we've got to look at residents and staff, and we've got to look at the routes of transmission. Why don't you go to the next slide? Okay, these are the deaths. And the deaths basically parallel the cases, which makes sense. But here, again, we have a very disturbing pattern, an increase through November. And it's going to be, if we extrapolate over the next month and a half, 2 months, we're facing a real crisis in the United States. So I'll end now and let my colleagues take over.
Thank you very much, Greg. Next, we've got David, or Dave.
Dave, thank you.
Hi.
Thank you, Greg. I'm speaking on behalf of Courtney Van Hootvin, who is tied up today. So this is much shorter than y'all have done. So about 40% of the deaths have been in long-term care facilities, including non-nursing facilities such as independent living, assisted care facilities, memory care units. As Greg was saying, we need to break chains of transmission within these facilities and communities, and we are failing miserably at that. Testing the United States federal policy has been to let it rip effectively and to hope that there would be sufficient testing in order to break local chains of transmission. That has never been the case. The most recent research coming out of Javier Internal Medicine has been that quite a few of these care facilities and nursing homes are unable to turn around a PCR test within 24 hours, which is basically what you need in order to break chains of transmission if you test twice a week. At this time, there's a little bit of hope. The testing supply chain has increased dramatically. We are producing well over 100 million tests per month, which is sufficient to actually test twice a week for both staff and residents at all types of long-term care facilities. And vaccines are being released as well, as Greg had mentioned earlier. The challenge at the moment is the December allocation of vaccines is well under 1% of the entire United States population. And a significant portion of that is being allocated correctly to frontline medical personnel. So even as there is hope on the way between the combination of increased testing, more rapid turnaround of even less of low specificity, but accurate enough testing, and then vaccines in January and February, the next 6 extraordinarily rough. And then finally on vaccination, as we go forward, we do not know what the optimal strategy is at the moment. We do not know if these vaccines only, and I hate to use the word only, minimize the consequence of exposure. If that is the case, then the effective target population should be the residents. Or if these vaccines break chains of transmission and keep people from ever being infectious, if that is the case, the targeted strategy should be towards staff and anyone else who interacts with the broader community around them. We do not know that. The trial information will not give us clear information about that for months, if we're lucky. So we're somewhat going in blind on this, and that is what I have. So next slide to the next speaker.
Thank you very much, Dave. I'm going to go to Mike Wasserman. Hi, Mike.
Hey, thank you. I want to thank Adelina for putting this together and all my colleagues. It's actually been fascinating to listen to everyone from around the world. But I also agree with Greg in terms of the worst of times. I think this pandemic has exposed both ageism and the lack of focus on vulnerable older adults in all parts of the world. You know, we have over 14,000 nursing homes in the United States. And what I'm going to briefly talk about is something we actually came out with that, as I've listened to all of you, I will still hold to this in terms of what needs to be done to combat this pandemic. And I will say we have facilities here that have done this and have continued to keep the virus out. We have others that have not. The one other thing I will comment on that we've seen lately with our latest surge, when community prevalence spikes to a high degree, it is very difficult to keep the virus out of a nursing home, care home, unless you literally have everyone doing all the things I'm going to mention here. So we developed what we called our quadruple aim. And I'm just going to go down the list on them. So sufficient, actually, I like to use the word abundant and properly used PPE. There is zero question in my mind that if you do not have PPE, if you don't have masks for all your staff, and also I'd add that they have masks to take home with them so that they are not getting the virus out in the community. But if you're not using masks in your facility, this virus not only wins, it can be quite devastating. I think we've talked about just now the twice a week testing. I think what we would all aspire to for staff in particular and visitors is that they have daily at-home test kits to make sure that they're not bringing the virus into facilities. So testing is an important tool. Infection prevention is something we've all been talking about for 9 months. One of the things we've been promoting here in the US is to make sure that every facility has a full-time person completely dedicated to infection prevention. And from a workflow perspective, we found this to be very important. Otherwise, in many of our nursing homes, the person who's supposed to be doing this job is pulled in multiple directions. And during a pandemic, that just doesn't work. The fourth item is being in your emergency preparedness mode. And it's been mentioned by a couple of other speakers, the importance of leadership and management at the facility level. Good leaders really can make a difference. And literally being in one's incident command mode is a proxy for good leadership. I'll make a final comment about the vaccine, because the vaccine actually becomes the fifth part of our quadruple aim and the fifth component of hopefully getting rid of the virus. I agree with what everyone said. I wish, and it's concerning and disturbing that the pharmaceutical industry didn't go out of its way to find opportunities to immunize in nursing homes and do studies in that population when what we're about to do is immunize everyone in nursing homes. It just boggles my mind. I saw in the chat box the mention about vaccine hesitancy, and here in the United States, we've already discovered from polling and surveys that a lot of our nursing homes on the front lines where, and I thank Elisabeth's comment on what an incredible job the frontline workers have done. They've been doing the most dangerous job in this country over the last 9 months, but there is a high degree of vaccine hesitancy. And we are actually developing education and training materials because the population that is vaccine hesitant is a population that historically has not been treated well by our healthcare system. And so requiring and forcing vaccination in this group might have some short-term benefit, but will have significant long-term problems. So with that, I just want to thank everyone. I think, I don't know if there's anyone after me, between being from the United States and having a last name starting with a W, I tend to end up last anyway, but I thank you all, and this has really been an honor and a privilege to be part of this.
Thank you very much, Mike. And we do have one more speaker, and the next letter in the alphabet is V for vaccines, which is obviously not a country, but I'm delighted to introduce my colleague, Shoshana Lauter from the Care Policy and Evaluation Center at LSE. And Shoshana has started just this week to compile data, information on prioritization of vaccines and the long-term care population. And she's assembled a great table, and we'd love to complete this with more countries. So I'll let her explain. Hi, Shoshana.
Hi. So hi, everyone. Thank you all so much for your presentations. It was really interesting. So like Adelina said, particularly in light of the Pfizer and Moderna vaccine rollouts, there's kind of been this, oh, I'm seeing some writing on the screen, but there's been kind of an explosion of plans produced by the advisory councils of countries that are preparing their prioritization plans for vaccines. And it's a little bit of a tedious process to read through those types of documents, but what's interesting is not only the language that they use, which I don't think will surprise many of you, but also the patterns of language that's not used. So using the kind of subgroups or populations that the long-term care COVID website kind of frames our research around, I started looking at what groups are kind of highlighted and which groups are not in these advisory councils recommendations. So obviously, like everyone has said, healthcare personnel, care home residents, care home staff are always at the top. This rather broad generalization of older people is highlighted in basically every country that I've looked at. Things that are of particular note is issues of long-term care residents who may be at home aren't necessarily mentioned. There's little language around people who are considered clinically vulnerable. In some countries, they're listed with developmental disabilities, autism. There are some countries that focus on other notable populations within their kind of top 5 groups. And that often includes indigenous communities that have been particularly hard hit in certain provinces of certain countries. But generally, when thinking about unpaid carers, care partners who might be entering homes of long-term care facilities, there's no mention of what kind of priority those people receive. And we'd love to keep adding to this list. There's a lot of material that is yet to come. So thank you all so much.
Thank you very much. I was a bit optimistic with going on 3 minutes per country, and there's a lot more. I see there's a lot of in the chat, and I couldn't see that while I was sharing my screen. But and we've got about 1 minute from the time we had, so we don't really have time for a proper Q&A session now. But we are going to start doing weekly webinars from January, so we'll be able to hopefully pick up the conversation and also go more in depth in some of the topics that came in today. But I want to thank all of you for your amazing contributions from all over the world. It's particularly interesting, but also sad to see how in some countries there's been some learning, but those were always the countries that seem to have been worse hit. And there's lots of questions about why is that and what Is it because the most vulnerable people died, or is it because of learning, which we all hope that that's the reason? And because we do see that the countries that was less badly hit in the beginning, maybe now are having a worse time of it. So there's so many questions that the research that all of you are doing will hopefully help to respond to. So thanks again, and we will put the recording available for everybody. We're very keen to hear from anybody who's been listening, who hasn't spoken, who would like to contribute to the next webinars, and also we'll have more thematic webinars coming. So do tell me which topic you'd be particularly interested to hear and talk about. And if you have any information on vaccine prioritizations in your country, especially if the main language in your country is not English, I think Shoshana would love to hear. Shoshana, would you mind putting your email on the chat box in case anybody is keen to share information with you? And thanks again. And just waiting for Shoshana to put her email through. Yes, there it is. So please, any information on vaccine prioritizations, but also anything that we could put to an international report on what's happening in terms of vaccines, please email Shoshana. So thanks again. We'll make the recording available, I hope before Christmas, if we can. I'm going to also add any links that any of the speakers would like me to add to their presentation. So if you have written papers that you think people would like to follow through, please also email me a message. So thanks. I hope you all have a good end of the year. Let's hope it's as good as it can possibly be, given everything. And thanks for all your efforts collectively. Being in contact with all of you has helped me personally cope with this year of so much difficulties. And I hope that all of you have felt that being part of this LTC COVID initiative has also helped in some way. Thank you, and see you next. Bye. Bye.